Okay, good morning, everyone, and welcome to session 5 of our RaCEEs course. Today's session is about analysis and results, and I'm very happy that today's session is co-run by Andy. Andy is the MIDAS theme lead, as many of you will know. So I just wanted to thank Andy for co-running the session with me today. As usual, the session is being recorded and will be made available on the ARC No West Coast channel, YouTube channel after the session. If you have any questions, just let us know. Okay, let's make a start. As usual, we are going to ask you whether you had any problems with the homework from our previous session. So as you remember, you were asked to fill in a table with the info on the outcome data and the discounting used in the economic evaluations. Do you have any quick questions for us now? Or are you waiting for feedback from the team leads? Okay, I guess we can go on. That's fine. If you have any problems, I know some of you will do the homework maybe in the next few days. Just let us know, of course. Okay, today's session is about the results. We are going to have a look at the base case and the sensitivity subgroup analysis. We will describe in a few minutes what these terms mean. And just to give you an indication of where we are in terms of the sections of the commentary, we've done the method. So we're now moving to the results section, and we're going to talk about the analysis. And after 2 days, you will have some homework about the results section. The homework will be mainly about interpreting the results. So we will try to give you some homework about, just understand what's going on within the tables and the figures of the results section of the economic evaluation. And then, of course, next session, which will be the last, we will talk a bit more about the introduction. And then we will have the commentary section, which will be done at the workshop. Okay, the aim of today's session is to understand and describe the results from the base case and the sensitivity subgroup analysis, and we will look at different things. First of all, I'm going to give you a quick definition of base case and sensitivity analysis. Then I will talk about the effectiveness results, the cost results in isolation, and then Andy will bring everything together and he will talk about the incremental cost effectiveness ratio, and he will also talk about the willingness to pay threshold. Then he will describe the net monetary benefit, and then I will talk a bit about the cost effectiveness acceptability curve. And then Andy and I will talk about common types of sensitivity analysis. So there's a lot to go through today. We will give you some examples as we describe the different concepts. So hopefully things will be clear by the end of the session. Okay, our usual depiction of an economic evaluation. We had a look at the costs in session 3, we had a look at the outcomes in session 4, and now we bring everything together with the cost effectiveness results. And typically what you will see in an economic evaluation is a base case analysis and a sensitivity analysis. So if you have a look at the results section of your economic evaluation, I'm pretty sure that you will have separate paragraphs for base case analysis and sensitivity analysis. And that virtually happens or should happen in any economic evaluation paper. So it's important that we familiarize ourselves with these terms. So with base case analysis, we basically refer to the results obtained from running an economic model with the most likely or preferred set of assumptions and input values. So with this definition, we really try to describe that the base case analysis concentrates on the average values, or let's say on the average patients. So if we are implementing the interventions to the average patient, we will get specific values for cost or specific value for qualis, for example. And this is what the base case analysis will focus on. So the most likely scenario in a way. But we know that the world is varied, there's a lot of diversity, there's a lot of difference among ourselves. So, if you implement an intervention to different people, you might get different costs, you might get different qualities or different results in terms of clinical effectiveness. So it's important to capture that kind of diversity or difference we have in the population, basically. And that's what we do with the sensitivity analysis. So with sensitivity analysis, we try to understand how the results deviate from those of the base case analysis when input values and or modeling assumptions are altered or changed. So we're trying to understand that, first of all, there is uncertainty in the world, there is uncertainty in our population, in the study population, and we need to capture that. In economics, in health economics, we say we need to characterize this uncertainty. So we need to be able to understand if we change the values for the cost, for example, what happens to the results? If we change the values for the qualities, what happens to the results, and so on. And by the way, these definitions are from this website. It's the website of the York Health Economics Consortium. And in this website, you will find a very, very useful glossary of health economic terms. We use it very frequently, and for example, to prepare slides for presentation or just to refresh our memory around some health economic terms. So if you struggle to understand some terms in the paper or and in other papers and so on, I suggest that you use this glossary because it's very good and it will help you understand the health economic terms a bit better. Okay, let's have a look at effectiveness results. So as you know from session 4, we had a look at the outcomes. So when we talk about effectiveness results, we are looking at how the interventions compare in terms of the clinical effectiveness or the composite outcomes. And this is a table which comes from the example economic evaluation we've been using during the course. So it's the economic evaluation which examines a new intervention for people with advanced Parkinson's disease. And in this table, which outlines the base case results, we're trying to have a look at the effectiveness results in particular. So we are looking at the second row and the third row here. And you got on the second column the new intervention, which is LCIG, is a new gel which is used for people with advanced Parkinson's disease. In the third column, we got SOC, which is standard of care. So as you will remember, we are comparing this new gel versus standard of care here. And let's have a look at the third row first. So this is LYs, which is life years. For the intervention group, at the average level, we got 10.64 life years, okay? For the standard of care group, at the average level, we got 10.28 life years. So there is a difference. And in particular, we can see that at the average level, the intervention group seems to do better, okay, in terms of life years. How better? There is a difference of 0.36 life years, and you can see that in the incremental column on the right-hand side. Similarly, for the qualities, you got a difference here because the intervention group seems to do better at the average level than the standard of care group. So you got 2.82 qualities here versus 1.43, and the difference in qualities is 1.39. So at the average level, and I will say this a lot, at the average level with this base case result, it seems that the intervention group is doing better in terms of effectiveness, or clinical effectiveness, let's say. Do you have any questions on this? Is everything clear? Okay, I'll carry on then. Cost results. Here we are doing the same thing as before. We're trying to compare the two interventions, but of course now in terms of total cost. And if you don't remember what total costs are, what we mean with total costs, please do have a look at session 3, at the slides or at the recording if you need to. So we are going to have a look at the first row now. And in particular, you can see the intervention group is associated with 586,000 approximately £1,000, while the standard of care is associated with approximately £554,000. So there is a difference here as well. In particular, we can see there is a difference of 32K or 33K. So the interventions group seems to be associated with a higher amount of cost, isn't it? So it seems to be more expensive than the standard of care group. So we are in this situation. In the cost effectiveness plane, you will probably remember this figure from our previous session. We are in this situation where we have a trade-off between effectiveness and cost. So the new treatment is more effective. We saw that. We got more QALYs, we got more life years. But at the same time, it is more costly. It costs more to implement a particular treatment. And this is a really common situation, because if you think about, if you want to implement a new technology, like a new type of surgery, for example, you need to buy a new medication, you need to start a new therapy, that involves cost, and you probably have to train the health or social care professionals in learning how to do that particular intervention. So there are costs associated with doing something new at the end of the day. At the same time, if you're implementing something, it means there is some promise that this new intervention will be more effective. So you got this trade-off between costs and effectiveness. And we need to decide, or we need to find some tools to help us decide whether these higher costs are worth the effectiveness we are getting. And how we do that, now Andy is going to guide us through the incremental cost effectiveness ratio. So I'm going to stop share the slides. Do you have any questions before we move to Andy's slides? Okay.
Valerio.
Oh, here we go.
It's not a question as such, it's a request. The YHEC website that you put on, could you put the link into the chat?
No, but I will do it now. Yeah, I can do that now. That's fine. That's fine. Andy.
Okay, thank you, Valerio. Hopefully you can see that now. Is that okay?
Yeah.
Right, thank you. Right then, so as Valerio says, we get really useful information on both the costs and the effects of the different treatments that we're looking at. But we need to bring them together to help make people be able to make decisions about them, to see what the benefit is of using a different treatment compared to what the usual treatment is in that. And there are a couple of ways of doing that. One is the incremental cost effectiveness ratio, which is on the screen now, and the other one is the net benefit approach. And it tries to give both of them try to give an unambiguous figure for decision makers to make their decisions about what to use the scarce resources on. So as you can see on the screen there, ISA is worked out by taking the cost of the new treatment versus, and then taking away the cost of the comparator, which is usual care, and then the same for the effect of the new treatment versus the current alternative, etc., and then dividing the cost by the effect, which is the incremental cost by the incremental effect. And basically that's telling you what extra cost you'll have to incur to get the benefit from the new treatment compared to the other treatment. On the table there is cystic fibrosis, which is a very problematic disease, partly because of the consequences it has for people, but also because of the availability of treatments. There are very few treatments available for it all. And there's some new treatments have been developed over the last probably about 6 or 7 years. One of them is called Orkambi, which is added to usual care. And this comes from a nice National Institute for Health and Care Excellence review of Orkambi from the manufacturer's submissions, where they looked to see what benefit there was of adding Orkambi to usual care compared to what usual care was, which is usually things like physiotherapy, etc., to help try and clear people's lungs of the sort of muck that builds up in them. As you can see from the table, by adding Orkambi to the usual care, you do get a benefit. You get a benefit of 3.46 life years gained, and similarly 3.45 QALYs gained from the treatment, but at quite a large additional cost of nearly £750,000 there, which if you work out the ISA, and you can do it for an effectiveness or a cost utility analysis, brings up for every additional benefit, in terms of every additional QALY costs just over £200,000. Now, obviously, the people who have the condition and their carers, etc., are going to want to have that funded. But what we have to work out is whether that's an appropriate use of the resources. So it's about deciding what is a good use of money from the use of that intervention. Would we choose that? Now you can produce these sorts of evaluations for all sorts, and here you'll see a list of what is effectively a league table of different interventions, which shows the spread, excuse me, the spread of cost per QALYs for different types of interventions that you might come across. So ranging from what is effectively public health advice, advice on stopping smoking, £270 per QALY. These are back from 1990, so the costs obviously would be a lot higher now, all the way up to different forms of surgery for tumours, etc., over £100,000 each. So how we do, because we have a finite budget, we have to work out how we decide which of those should be taken forward and which ones we wouldn't necessarily do so. We do that by, or decision-making bodies do that by setting thresholds. So this is the willingness to pay threshold, which is effectively the amount that whoever's funding it, whether that be a country or a particular organisation, etc., is willing to pay to get that extra benefit from the new treatment. They vary tremendously depending on which country you are in. So the World Health Organization sets a threshold of between 1 to 3 times a country's gross domestic product per capita per QALY as their threshold. China uses 0.5 to 1.5 of GDP per capita per QALY as their threshold. In the UK, I assume you'll all have heard of the National Institute for Health and Care Excellence, NICE, and they don't explicitly set a threshold out there. They have identified thresholds sort of implicitly through the decision making that's undertaken. So they have a range, and the reason they have a range is because of the degree of uncertainty, which Valerio mentioned earlier on, as to all those different variables that should be taken into account in undertaking health economic analysis. So they have effectively what is 3 levels. They have an ISA of up to about £20,000 per QALY gained, or £100,000 for specialised technology. And specialised technology is one which is for people. It's usually rare diseases that affect people, where there's about 5 per 10,000 people that suffer it. So inevitably, it's going to cost quite a lot more because of the pharmaceutical companies are going to need to recoup their money, and there's going to be a very small population to do so. So the cost per QALY for those is much higher. So they set the sort of a benchmark of that threshold level at the £20,000, of which they would normally recommend that intervention based on the ISA that's available and how acceptable it is to being able to actually implement the intervention within the NHS, within its budget. So a few years ago, it was shown that bariatric surgery for morbid obesity was very cost effective, but to actually implement that within the NHS is very challenging because it would effectively consume a phenomenal amount of resources. So they have to be judicious around how they undertake that implementation. The other levels are between 20 and 30 per QALY, or over 30 per QALY. They have to justify in terms of understanding how much uncertainty there is around the ISA, so how certain they are that the ISA is correct, and then other elements are associated with the benefits that might be there but haven't necessarily been captured, etc., that they think may influence that cost per QALY. So they can then provide a recommendation based on that. If they're not going to recommend below 20,000 per QALY, then they have to give a justification on similar sort of factors to indicate why they've made that decision. So it all gives a certain amount of how can we put it? Sort of it's that balance between transparency of decision making and trying to help sort of that political challenges that are there amongst those decisions that are made for the different people. Okay. Scottish, you may have heard the Scottish Medicines Consortium, which is effectively what NICE is in for Scotland. And these just gives you an indication, this list just gives you an indication of the types of factors that they take into account when they're making their decision. They also use an ISA of about £20,000 per QALY associated with that, but they take into account the uncertainties around life expectancy, quality of life, and other benefits that are there that may affect their decision. And for the specialized technologies, which are also known as orphan drugs, they also have elements. So if something's a treatment of last resort for a population, then they will probably favor giving a recommendation associated with that intervention there. Okay, anyone, any questions? So these are the sorts of decisions you may have seen these if you've ever looked at NICE guidance or hear it on when they announce it on the TV, radio, etc. They will give a range of different recommendations based on how the degree of certainty they have around their decision, from something that's fully supported to not supported, with a range in between that, where they will do such things as recommend with research to try and identify and make greater certainty around those different aspects of the population, the benefit, the cost, etc. involved, so they can move towards, over a period of time, ensuring that they can fully support the use of that technology there. And uncertainty is a really important aspect within all these evaluations there. Okay, so unfortunately there are issues with the use of ISAs, which relate to probably more their statistical properties than anything else, because of effectively they're a ratio within that. So two particular problems are negative values that you can get for ISAs, and also when the denominator, the effect difference is 0. So you can see in this comparison, you effectively come up with two ISAs that are the same, -10. The issue associated with that is that in comparison A, you can see that the new intervention highlighted in red, is at a higher cost than the standard intervention, so 80 compared to 60, and it has fewer benefits, so 5 compared to 7, which suggests that the new intervention is dominated by the standard intervention, and giving an ISA of -10. Now in comparison B, it's the reverse. So the standard intervention gives fewer benefits and costs more than the new intervention, which gives -10 as its ISA. So if a decision maker was given those sorts of figures, it would be difficult for them to interpret those unless they know the detail behind it. So if they were aware that where it fitted on the cost effectiveness plane, it would probably be slightly less of an issue, but it still is difficult to interpret those figures which suggest the same thing. Also, if you have a denominator that is 0, so the effect is 0, your ISA becomes infinite, which is obviously very tricky to interpret within that. So another option has been put forward is the net monetary benefit, and you can also have the net health benefit associated with that. And this is where we take the willingness to pay threshold, that £20,000 say, and we multiply it by so we're effectively turning it to a monetary value, and then taking away the costs. So that is then interpreted in the line, it's the green line there, which is the incremental, because we're always judging one treatment against another treatment to see which is better in terms of benefit and cost. So it's the incremental benefit times the willingness to pay threshold minus the incremental cost within that. So in most cases, it's going to be the QALY that's used associated with that. So it's the difference between the QALYs that the treatments offer times the willingness to pay threshold minus the cost. If you get a positive value, it suggests it's cost effective. if you get a negative value, it's not. So just going back to the example of the Orkambi compared to standard care for cystic fibrosis, as you can see from the calculation there, it is a very large negative value, and therefore you would say it's not cost effective, and therefore you would hope that the decision that was made was not to recommend that treatment. Anyone any questions around that? So this is another case which is another intervention that's been introduced, and some people might recognize it, which has the total cost per patient, total QALYs and QALYs per patient. And what we're going to suggest is that if you want to have a go at working it out, not now obviously, but as part of the homework, you're very welcome to have a go at working it out. It's both has the net benefit, net monetary benefit, and the net health benefit from those, and the formula at the bottom of the slide there, which you'll be able to get later. The health benefit is just altering the formula around. So instead of having it, the incremental cost is divided by the threshold and then taken away from the incremental health benefit. Okay. Over to you, Valerio.
Thank you, Andy. I think we got a question from Maria.
Yes, thank you. I just wanted to check about the willingness to pay threshold when they say, for example, 20,000 per QALY. Is this per QALY per patient or per QALY per patient group?
It will be as Valerio said earlier, it would be for an average person.
Average person. Yeah. Thank you.
Okay.
Thank you. Any other questions? Oh, share my presentation again. Okay. Here we go. Okay, thank you, Andy. So with this slide, I'm going to start talking now about how we capture uncertainty in an economic evaluation. And this is a graph depicting the cost effectiveness acceptability curve. And again, it's something you will virtually see in any economic evaluation. So you can have a look at your particular paper after the session, and I'm pretty sure you will find one of these. And it's important so that we understand what's happening here. And by doing so, we also start talking about uncertainty and sensitivity analysis. Right. So this is again coming from the example economic evaluation we've been using during the course, the economic evaluation which examined the new intervention for people with advanced Parkinson's disease. And we're looking at figure 5. In this figure, on the horizontal axis, you can see costs, or let's say monetary values better. In particular, these monetary values reflect different willingness to pay thresholds. So willingness to pay threshold has been described a few minutes ago by Andy. On the vertical axis instead, you got percentages, and these percentages reflect the likelihood or the probability of the treatment being cost effective. Okay, the new treatment being cost effective. Now, without looking at the particular paper or the particular healthcare interventions here, just connecting this figure to our everyday lives. If you have more money, so if you go to a supermarket with a lot of money, let's say, you are more able to buy certain things, so you are more able to accept the purchase of certain things. So that's what the graph is doing here. If you increase your budget, so if you move from the left-hand side to the right-hand side of the graph, you're able to implement the intervention more and more, and so the likelihood of the intervention being cost-effective will be higher and higher. In particular, as we move towards, let's say, 80K or 100K, you will see that the probability of the intervention is really going towards 100% nearly. So that's the kind of interpretation behind this graph. Now, looking at the particular curve here, which is associated with the gel, the new intervention the authors were testing or evaluating in this paper, we need to concentrate on a few things. First of all, at 0, so where you got £0, the curve is basically at 17%, probably something like that, 17, 18%. So that means that if you were to implement this new intervention, there is a 17% probability that the intervention will be cost saving. So that means if you don't have any money, but you still want to implement it, there is about 17, 80% probability that the new intervention is going to be cost saving. As you increase your budget, so as you are able to invest some money in implementing the new intervention, the curve describes the likelihood of this intervention being more and more cost effective. In particular, if we look at the UK threshold, for a budget of 20K, the intervention will be cost effective with a probability of 40%. 30K, which is the upper value in the threshold for the UK, the intervention will be cost effective with a probability of about 55%, if I remember well. Okay, so this is where we are in terms of the UK threshold. Of course, other jurisdictions might have different thresholds, but for the UK, we were trying to consider what might happen in terms of the likelihood of the new treatment being cost effective here. All this to say that with this graph, we are trying to capture uncertainty at the end of the day. We are trying to see, okay, we got this budget, but what if the budget changes? What if our willingness to pay is changing? So, you know, this might have an effect on the likelihood of the new intervention and being cost effective. So we are trying to capture what might happen to the results when we are changing our willingness to pay threshold at the end of the day. And in terms of uncertainty, in economic evaluations, you will see different analyses around the uncertainty and how researchers go about trying to minimize or trying to capture the uncertainty around the base case results. In particular, you will see different types of uncertainty. First one we are seeing here is the variability. So this reflects unexplained differences between people in the sample. So we might respond different to certain intervention because of our genetic factors. And this is more or less unexplained because it's not always possible to measure, to capture these type of factors. Heterogeneity, instead, we are referring to explainable differences between people in the sample. So how we react or how we respond to particular interventions due to our age, to our gender, and so on. So all things that we can measure. Parameter uncertainty, instead, is really focusing on the impact of changing the values of certain parameters like costs, outcomes on the results. And then another type of uncertainty, which is not commonly investigated, is the structural uncertainty. Is a bit more complex, and this reflects the impact of changing the model assumptions on the results. So, for example, if we are implementing a decision tree in our base case analysis, in the sensitivity analysis, we might want to implement a Markov model to see how the results change, right? Or if we are including, excluding certain alternatives, certain comparators from the analysis, or if we're including, excluding certain health states from our Markov model, how all these changes impact on the final results. So as you can see, we got different types of uncertainty, and now Andy and I will describe each one of these one by one, apart from structural uncertainty, because as I said, it's not that common, not that commonly investigated. Here we go. So I'll stop sharing, but do you have any questions? Oh, okay. We got Will, I think, yeah.
Thanks, Valerio. It was just a question about the types. Would it be possible to put the screen back up? Sorry,
oh, yeah, sure. Sorry.
Just so I can remind myself what the categories are. But is there a possibility of one type being moved to another? For example, on the previous slide, yes, I think you used the example of genetic factors. So if we, for example, investigate genomes for the patients that are involved in the study, and we understand what those genetic factors are, could they therefore move from the variability category to the next one down, the heterogeneity?
No, yeah, that's a really good point. Yeah, you can, yeah, and that's something I was thinking about by looking at our paper, isn't it, Will? So of course, with the is looking at genomics. So yeah, of course, genetic factor used to be one of the typical example where I think a typical example of a factor that cannot be measured. So we can't really explain what's going on, but now it's becoming more and more common now to have tools with whom we can measure a genetic factor. So of course that could move into the heterogeneity area, let's say. Yeah, absolutely.
Thanks. Thank you.
Any other questions? Stop sharing then. Andy.
Thanks. Not quite sure what's. Okay, I think Valerio, to a certain extent, you've probably explained this already in your previous slide associated with the variability and the heterogeneity. In the fact of what you've said and what you've just chatted with Will about is that variability is differences that occur by chance, random chance, etc. within it, and therefore they're captured in an analysis, tend to be captured by measures of that variability through such things as standard deviation. So the example I had was 20 asthma patients for experience exacerbations. That's a 20% chance that you'll have that the patient will have that exacerbation, but in reality, it's actually something that it either does or doesn't occur within it. So they don't necessarily relate to each other. So that's the variability within it. And heterogeneity, as Valerio has already said, is something that can be explained, or we can find out more about it, etc. And the example was mortality rates varying by sex of and age of the patient within that particular group. So those are just some simple examples of those two. So if I move on to how do we, as we've talked about, uncertainty is a word that's commonly used associated with all these forms of analysis and trying to decide how we sort of quantify that uncertainty within the analysis that's been undertaken. And the first one I'm going to just briefly talk about is deterministic sensitivity analysis, and Valerio will be looking at probabilistic shortly. So effectively, deterministic sensitivity analysis is going about looking at the analysis you've undertaken and changing variables within that to see what the consequences are on the outcome associated with the cost per quality that comes out of it. And you can do it either by just changing one variable, or probably a maximum of 3 or 4 variables in an analysis. So that means looking at what effect changing the costs or the benefits would be, for example, within that population, or examining other factors that might affect it and seeing what the consequences are within it. But usually they're predefined before we start the analysis, and can look at different ranges of confidence interval, or making certain assumptions that if you change it by a proportion, see what the consequences of that are, or just exploring it in those different ways. And what you do is you undertake that analysis by changing those variables, and then you can present them in such things as tornado plots. Now the plot basically has a number of variables down the side there that have been used in the analysis, and this is one of the papers that's being encompassed in the RaCEEs project. And you look at what the consequences are of looking at different extreme values, as I said before, that are usually predetermined, and does it affect the outcome significantly, and which ones have the sort of greatest uncertainty. You could then potentially go and investigate further and see whether you could improve the information that's available within it. So this is looking at the effects in terms of on the net monetary benefit, and obviously the line there, the red dotted line on the tornado plot, shows the point at which it goes from positive to negative. So it identifies when it becomes not cost effective anymore within that. But you'd also want to look to understand why these values are so variable within it. So there's greater variability up at the top of the plot, decreasing going down there. So you can identify which of the variables you think are the ones that may determine the relationship that exists there, and that you need to have greater information on those and explore that further. And then you can also do the same. This is one on the ISA, where again, tornado plot demonstrates those that affect it. And you can see where the thresholds would fall within it with 20 and 30,000 over there to see what happens as you go through that, those different characteristics there of uncertainty. Anyone any questions about those? Okay, and back to Valerio.
Oh, thank you, Andy. Okay, I'll share my screen. So Andy was talking about deterministic sensitivity analysis, which often is accompanied by another type of sensitivity analysis, which is called probabilistic sensitivity analysis. It's a bit more complex to implement, and because it's based on the distributions of the parameters. Now, I'm not expecting all of you to be familiar with the statistical terms, so I'm going to try to explain what we mean the distribution in statistics in a minute. But let's have a look at this figure together. So this is from a paper. You can find the source there if you want to have a look at the paper. In particular, figure 2. Figure 2 is about the cost and quality distributions for APBI alone. APBI is just the name of an intervention, so we don't need to worry about this. And then AI alone, which is the name for another intervention, and their combination, okay? So in this figure, you got basically the distribution of the value for the cost, the distribution of the values for the qualis for each intervention, and then for their combination. But let's concentrate on the figure at the top left-hand side for a minute. So here are the costs associated with the intervention, which is called APBI. So horizontal axis, you got monetary values. You can see the monetary values here at the bottom. So from $10,000 up to $22,000. And in particular, on the vertical axis, you can see basically a measure of how many people are associated with a particular amount of cost. For example, this bar at the just right in the middle of the graph, you got a lot of people associated with this amount of cost. So let's say maybe if you have 1,000 people in your sample, let's say maybe, I don't know, 200 people are associated with that particular amount of cost. So there's a lot of people associated with that. And as you move towards the extremes of the graph, so to the extreme right, to the extreme left, the amount of people associated with those particular values of cost are quite low. So that means it's quite unlikely to have these particular values of cost here, but it's very likely to have a value for cost, which is here represented by the bar in the middle. In the same way, we can look at qualis, for example. Qualis, on the right-hand side here, you got a lot of high bars. So you probably got an average, which is probably right here, somewhere in the middle here. But there are a lot of value which is above the average and below the average, which are quite likely if you think about it. So there are a lot of people associated with values which is below or above the average qualis. And that means, you know, if you're only looking at the average patient, you're failing to look at what happens below the average or what happens above the average. And these are likely scenarios at the end of the day. They're not things that are so unlikely. So of course, if you look at the extremes value for the qualis, yeah, you got not a lot of people associated with that amount of qualis. But here in the middle, there are a lot of bars which reflect a lot of people associated with different amounts of qualis. So here is how we look at the distribution, basically, for our costs, for our qualis. We could do that. We could look at other parameters as well. And it is important to understand how these values are distributed. And moving to statistics, now each distribution could be reflected in a particular statistical distribution, which I'm not going to go into much detail today. And by looking at a statistical distribution, we can do something. We can perform a probabilistic sensitivity analysis. What does it mean? Basically, it's like randomly drawing a value for the cost, a value for the qualis from an hypothetical distribution, knowing that certain values are more likely than others, and doing this random drawing several times. Like researchers do that 1,000 times or 10,000 times using software. Of course, they don't do it, with a piece of paper, but they do this simulation of different combination of cost and qualis several times in order to capture the uncertainty around the values for the cost and the values for the qualis. So, for example, you draw a random value for cost, a random value for qualis for intervention A, a random value for cost, a random value for qualis for intervention B, and then you do an ICER. And then the same for the second draw, for the third draw, and so on and so on and so on. You repeat it so many times that you are going to get a lot of combinations of cost and qualis, or life years, for example. So looking at our example economic evaluation, going back to the advanced Parkinson's disease paper, here you got the different combination of incremental cost and incremental qualis. So if you look at this dot here, for example, at the very top of the graph, this dot is associated with an incremental cost of about £140,000, and at the same time is associated with the incremental qualis, which is about 1.20. Okay, so you got higher qualis, higher costs, so you are in this situation where you need to decide what to do, basically, whether the higher costs are worth the higher quality you're going to get from the intervention. At the same time, each dot is associated with different incremental cost, incremental qualis. Now, you're not going to analyze each dot one by one or each combination by one, but what you can see from looking at the graph is that most of these pairs, most of these combinations, let's say, they lie in the northeast quadrant, where the new gel is associated with higher cost and greater quality gain. There are also some dots which fall in the southeast quadrant, where the new gel is cost saving. So this is a reflection that some of the combination of cost and qualis might result in the new intervention being cost saving. But we have to also consider that most of the combinations will lie in the north east quadrant, where we have this trade-off between cost and qualis. And of course, having a willingness to pay threshold will help us decide whether the new intervention will be cost effective or not. Now, if without now drawing things, but if the new, if your willingness to pay threshold is here, you're gonna set a lot of combination. If the new willingness to pay threshold is here, you're gonna set a lower amount of combinations of cost and effectiveness pairs. Any questions on this? So just to conclude this today's session, this is an example of how we capture the results from the paper on advanced Parkinson's disease into our RaCEE, how we extract this info, and also how we wrote things up. So I'm not going to read things here, but you've got the different paragraphs associated with the base case analysis, the incremental cost effectiveness ratio, the cost effectiveness acceptability curve, the deterministic and the probabilistic sensitivity analysis, and also the scenario analysis, which is implemented by researchers in order to understand what happens to the results when you have an alternative population. Maybe you have a patient with higher severity or lower severity, let's say. So you could change that kind of assumption and see what happens to the base case results, basically. Okay, now we got the homework, but before we move to the homework, any questions on today's session? Right, okay. So today's homework is about looking at the results from your own economic evaluation paper. And what I did, I tried to look at the main tables and figures from the results. And I will try to formulate 3 questions for each team, which will help you interpret the results from your paper. And you can complete this task by Monday, the 22nd of July. As always, you can access the homework by going into the relevant folder on your team space, session 5, and then you will see a document with your name. And into each document, you will see a table from the results, or a table and a figure, and there will be 3 questions related to those particular tables and figures, just to help you interpret the results a bit better. And if you have any problems, as always, let us know. We are here to help you. Maria.
Yeah, sorry, just a quick one, something that stayed with me from earlier when we were talking about how something can be within the willingness to pay threshold, but can't be implemented in the NHS because of other factors. So I was just interested whether this is the implementation element is not something accounted for in the study, in the original study, before the cost effectiveness is even calculated, or is it something not related to costs at all?
Oh, Andy, do you have any thoughts on this?
So we are saying that so effectively, if you had an intervention like the bariatric surgery for obesity I mentioned, and the fact that it would be a large cost to the NHS, is that taken into consideration? No. Well, it's recognised as a factor, but the decision is made basically on the cost per quality associated with it. Would it provide benefit? It's then up to the NHS how it implements that. So the decision maker it almost ignores the budgetary impact of it all. There are statements about the budgetary impact and a recognition of the consequences of it all, but then the NHS has to work out how it implements something.
Right. So the decision is made solely on the sort of cost effectiveness analysis, and then if it's recommended, the NHS figures out how they would implement it.
Yes, yeah, they sort of divorce the two from each other, so that so they make a decision around the technology. Is it effective? Is it cost effective? And then a separate decision is made about whether it can actually implement it, and that's usually then put to the NHS, the people who are the medics, etc., who are there, who then have to make the decision about it. And each health ICBs now will have to make that. They'll have a panel who make decisions about interventions around that sort of decision that they have to make around the costs for them, and the implications in terms of costs for them.
Yeah, that's interesting. So I wasn't aware that implementation is not considered. Something is taken up to the point of a nice decision, but implementation is not considered. It's really interesting to hear about that.
There's an element where they do, but they still give guidance around things being recommended. That's why they don't have it an explicit ISA, etc., because then they can have that careful political decision around some interventions.
Oh, thank you.
Oh, thank you. And any other questions? Okay. Because if you have questions about the homework, let us know, and we will see you on the 22nd of July for our last session. Actually, that session we will cover things like the introduction of the RaCEE. We will talk about the commentary as well. So we will talk about what to expect at the workshop, but it's also a Q&A session. So if you have any questions in your mind, feel free to send it to me. We will discuss them at the next session, or you can just we can just talk about your questions directly at the session. So prepare some questions for our next session. And if you have any question about this session, please let Andy and myself know. And apart from that, I just want to thank everyone for attending today, and it's great to see you. And yeah, we will see you in a couple of weeks' time. Thank you, everyone.